Welcome to Pathology Central Key Concepts. The topic of this video is syphilis. In this video, I will focus on the pathophysiology of this disease, comparing and contrasting the morphologic findings and clinical consequences of the different stages. I believe that every discussion of syphilis needs to begin by acknowledging the Tuskegee study of untreated syphilis in the Negro male. This was a study that was performed by the United States Public Health Service beginning in 1932 with the enrollment of 600 black men. 399 had syphilis and 201 did not. They were largely of low socioeconomic status. Now, the stated goal of the study was to examine the natural history of untreated syphilis in this population. And it was based on the belief that there are biological differences between socially defined races, such as African American and European American. And this belief that there are biological differences across socially defined races remains to this day. Now, even in the 1940s, when it was recognized that penicillin was a treatment for syphilis, study participants were not treated. And in fact, it was only on July 25th of 1972, when the Associated Press published a news article about this study, that this came to the attention of the wider American public. Now, up until this time, this was not a hidden study. It was known about by the medical community. It was published in medical journals. On October 1972, the study ended. Now, I include this image, which shows photos of some of the study participants, because when we look at numbers like this, it can be hard to remember to recognize the individuals who were involved in this study. It helps sometimes in that regard to look at the consequences and casualties. From the study, 128 men died of syphilis or related causes. 40 wives were infected with syphilis, and 19 children were diagnosed with congenital syphilis. And we'll be going through each of the stages of syphilis, and I challenge you to keep in mind these casualties. With that in mind, let's begin our discussion of syphilis with the natural history of the disease. So it begins with infection with Treponema pallidum, which is a spirochete. They're called spirochetes because they are spiral in shape, which you can appreciate these little wavy organisms here. This is an immunohistochemical stain for T. pallidum. We divide syphilis into early and late stages. The early stages include primary, which is characterized by a painless chancre and perhaps some lymphadenopathy. Secondary syphilis, which has systemic symptoms and rash. And then there can be a latent period in which the patient is asymptomatic, and some patients will then go on to develop tertiary syphilis with late complications of skin, heart, and brain. Now, this is an excellent figure from Robinson Kumar Basic Pathology that puts all this together, and we're going to work through this step by step, beginning with primary syphilis with the chancre, the end arteritis obliterans, and the lymphoplasmacytic infiltrate. So here, as we look at primary syphilis, it occurs about several weeks after infection. The patient will present with a painless chancre at the point where the spirochete enters. So this may be on the penis or scrotum or vulva or vagina. Abundant spirochetes are present, and there will be hematologic and lymphatic dissemination. While there will be a host immune response, it does not eradicate the organism. Clinically, we'll see a slightly elevated, firm erythematous papule that erodes into a smooth-based, painless, shallow ulcer. Patients may also have enlargement of regional lymph nodes. Now, microscopically, we're going to see a dense lymphoplasmacytic infiltrate and a particular lesion called end arteritis obliterans. End arteritis refers to inflammation of the arterial wall, and obliterans to the occlusion of the lumen. In addition, using immunohistochemistry, as I showed you on the previous slide, we can see abundant spirochetes. So here are the primary chancres that we can see. You can see one here on the penis, as well as here on the scrotum. And this is an important consideration because when you see that you have them on the scrotum or vulva, this helps to indicate that condoms are not adequate for protection against syphilis, although they do offer a reduction of risk. In addition, we can see this lymphoplasmacytic infiltrate. Let's take a closer look at that. You can see here we have abundant plasma cells circled here in red for you, as well as lymphocytes. And then regarding endarteritis obliterans, here's just a beautiful example where you can see this inflammation in the arterial wall and this obliteration of the lumen. This is going to become important when we talk about late complications of syphilis, because when this occurs in the vasa vasorum, it can result in necrosis in the aortic wall. So this brings us now to secondary syphilis, which will be characterized by lymphadenopathy, palmar, plantar, and sometimes truncal rash, and condyloma latum. So for most patients, they'll undergo spontaneous resolution of their chancre over 4 to 6 weeks. And about 2 months later, we'll get systemic symptoms in about 25% of untreated patients. This will consist of generalized lymphadenopathy as well as mucocutaneous lesions such as the palmar, plantar, truncal rash, and oral lesions. These will be red, brown, or hyperpigmented with scaly pustular appearance. And microscopically, we will again see this endarteritis and abundant spirochetes. Condyloma lata are broad-based elevated lesions that you can see in the anogenital area. So here are this is the characteristic palmar rash of secondary syphilis. You can see it here on the torso of this patient. Now, what do we see microscopically with that rash? Why is it scaly? Well, we have this hyperkeratosis, which you can appreciate here. But what is really the hallmark here is going to be this dense lymphoplasmacytic infiltration. And what's very interesting about it is that it's concentrated around the blood vessels. So this is a perivascular lymphoplasmacytic infiltrate. And you can see here on this higher power, there's the vessel with the lymphoplasmacytic infiltrate. Here's a little plasma cell here, and here, and here. And you can see there may be some early obliteration of this lumen. And again, we are going to have abundant spirochetes, which we can see here on immunohistochemistry. Condyloma lata is a broad-based elevated lesion, which you can see here. It has a less frond-like or papillary appearance to what we see in condyloma acuminatum. And condyloma lata are quite uncommon. We don't see them very often. Then the patient will go into a latent phase. Latent phase is described as more than 1 year after the initial infection, with the patient being asymptomatic. And about 1/3 of these patients who are not treated will develop additional symptoms over the next 5 to 20 years, and this will be tertiary syphilis. So here again, we look at our figure and we see we're going to be looking at neurosyphilis, aortitis, and gummas. So what are we talking about here? So in neurosyphilis, we get a couple of different lesions. One is we can get meningovascular changes that over time will lead to what is referred to as general paresis, which is a cognitive decline, seizures, and psychiatric disturbances. In addition, we can see Tabis dorsalis. Tabes means emaciation, and dorsalis is referring to the dorsal columns. And I'll show you an image of that in a moment and discuss the clinical significance. Aortitis I've already referred to. We see that in about 80% of cases, and it's due to endarteritis of the vasa vasorum, again causing ischemia and necrosis in the aortic wall, which can lead to aneurysms and aortic regurgitation. Gummas are nodules of coagulative necrosis with peripheral epithelioid macrophages and mononuclear lymphocytes, and these actually look very, very similar to what you would see in tuberculosis. We will be able to see spirochetes, but they are scant. And these lesions can arise in the liver, where they can mimic metastatic carcinoma, skin, bone, brain, etc. So regarding Tabes dorsalis, here you can see that with long-term syphilis infection, we get chronic inflammation of the dorsal roots and ganglia, which leads to degeneration of the dorsal columns. And you can see here, this is evidenced by this pale staining, the degeneration here of the dorsal tracts. And the consequences of this will be shooting pains and or paresthesias. And because of this, the patients may have joint trauma or damage due to this lack of sensation. This is referred to as neuropathic arthropathy. We can see this in other conditions as well, such as diabetes. And because of decreased proprioception, patients may have a shuffling gait. Here is an image showing the aortic wall. These are the vasa vasorum of the aorta, and you can see there's this scant mononuclear infiltrate around the vasa vasorum. Not particularly dramatic, but something that we can see in syphilitic aortitis. And then regarding gumas, grossly, they are white, gray, rubbery, solitary, or multiple. They can affect the skin where they appear as a nodule that has ulcerated. And microscopically, you can see this looks very similar to the granuloma we see in tuberculosis with coagulative necrosis, palisading epithelioid macrophages, and scattered plasma cells and lymphocytes. So that brings us to the end of our discussion of the primary, secondary, and tertiary stages of syphilis. We also need to consider congenital syphilis. And we will define this as infantile, which is diagnosed before the age of 2, and childhood, which is diagnosed after the age of 2. So let's look at that first and consider that the risk of maternal-fetal transmission is greatest in primary and secondary syphilis because that is when we have the highest concentration of spirochetes. Now, early congenital syphilis may present as stillbirth, or we can see a variety of other manifestations, some of which mimic what we see in secondary syphilis, such as the generalized lymphadenopathy and mucocutaneous lesions. However, the mucocutaneous lesions will be more severe than what we see in secondary syphilis. There can also be fibrosis of the lung, pancreas, and liver. The late findings include optic nerve atrophy and eighth nerve deafness due to meningoencephalitis. We can get interstitial keratitis, which is inflammation of the connective tissues of the cornea, which leads to clouding and vision impairment. Hutchinson teeth are small peg-shaped incisors with notches. And then we get a periostitis, and the bone that is reactive to that inflammation will cause excess growth, and we can get anterior bowing of the shins or femurs. This is referred to as saber shins. And here are some examples. We can see the corneal clouding here, the bowing here of the femur, and then these are the Hutchinson teeth. And just to finish up with a discussion of laboratory testing in the diagnosis of syphilis. So we have two categories of tests, non-treponemal, which are not specific for T. pallidum, and treponemal, which uses antibodies to T. pallidum. So the non-treponemal tests include the RPR and VDRL tests, so Rapid Plasma Reagent and Venereal Disease Research Laboratory. And what they measure is antibodies to lipoprotein and cardiolipin antigens that are released by cells that are damaged by the spirochete. They're detectable 4 to 6 weeks after infection, so a few weeks after the chancre appears. Titers will decrease over time, so it's best for diagnosis of primary and secondary syphilis. Titers will also decrease with treatment, so it can be useful for follow-and response to therapy. Now, we can get false positive results in systemic lupus erythematosus due to autoantibodies to lipoprotein and cardiolipin. In the treponemal tests, these, as I mentioned, are using antibodies to T. pallidum, so they're very specific for the lesion. However, since once an antibody is generated, we will maintain that through our memory B cells. So we will be using this mostly for identifying tertiary and latent syphilis. And because once the antibodies are generated, they don't decrease significantly over time, this cannot be used to monitor response to treatment. So here are some questions to see how well you've understood this video. As always, thank you very much for your time and attention.